Welcome to the Nourished Child Podcast, a show about childhood nutrition, feeding kids, and dealing with the ups and downs of growing a healthy child. Here's your host, registered dietitian and childhood nutrition expert, Jill Castle.
Hey everyone, welcome back to the Nourished Child Podcast. I'm Jill, your host, and today I have a special guest, someone I've been wanting to have on the show for quite a while, and particularly to talk about this conversation, which will be about how pediatricians work with children who have larger bodies. And today on the show, I have Dr. Zeena Al-Rufaie. She is a board-certified pediatrician who graduated from medical school from the University of Tennessee, completed her pediatric residency at Children's Hospital of Michigan, and she's been working in private practice pediatrics for almost 15 years. In 2021, she became a board-certified pediatrician in obesity medicine and also became a certified life coach. She has her own private pediatric obesity clinic located in the suburbs of Detroit. She is just darling, passionate about working with patients and their families who are growing up in larger bodies, and focuses on delivering care that is comprehensive, non-biased, and patient-centered. We talk, Kids Thrive at Every Size. My newest book really centers around the lifestyle habits that I believe every family should be instilling in their children, no matter their size. And, but sometimes we have children who are growing up in larger bodies and they develop health concerns related to their size. And I wanted to have on a pediatrician who could give us some insight into how she works with children who may be also having some significant health concerns or conditions related to their size. Dr. Zeena is here to talk us through how she thinks about this. And I think you will enjoy this show and find it quite balanced. Here she is. Welcome, Dr. Zeena. It is so nice to have you here on the show.
Thank you, Jill. I'm very happy to be here with you.
Well, before we get started, why don't you share with the audience the work that you do?
Yeah, absolutely. So I'm Dr. Zeena Al-Rufaie. I'm a general pediatrician. I've been in practice for almost 15 years in Southeast Michigan. And I also practice obesity medicine. So this was something that I got board certification in 2021, became a passion of mine. And so now I also have a private clinic on the side for pediatric obesity as well.
Nice. And what sort of is it a large population that you take care of, or what are sort of the demographics of the clientele that you're working with?
Yeah. So I practice in suburban Detroit, so it tends to be more middle and upper class families. So there is obesity there, maybe not as much as lower income households that we all know about does exist, and the disparities that exist in our communities. And treating obesity in each environment is unique. And so I tend to work with families who, instead of having a lack of access, may have an excess of access to resources, which would be different.
What we're going to talk about today is really how we work individually with children who have larger bodies, and how pediatricians and dietitians could work together, sort of how we got here. And I know I've been working in pediatric nutrition for almost 34 years now. And the war on quote unquote obesity has been going on for the last 20 years, the last 2 decades. And, a lot of people will say we're getting nowhere and things are getting worse. And I'm just curious, when you hear that, what does that bring up for you?
I definitely would say there is some concern in that we are seeing more severity of the illness. There are studies that say there's an increase in the quantity as well. Mm-hmm. And I think there's a lot of factors involved in it, including our lifestyles. If we look at our lives now compared to 20 years ago, There's a lot more technology that's involved. The food environment has evolved. So there is definitely an increase in concern. But I also don't want families to feel panicked at the same time, because we also have a lot more treatment options and ways we can help, which I think is very important compared to the last 10 years ago. We really didn't have many options. So there's been a lot of innovation more recently, which is really exciting.
For sure. And, we were talking a little bit ahead of this. And just so the audience knows, we don't know each other. We just met each other, right?
Yes.
And I think maybe you found me through the book that just came out that I wrote, Kids Thrive at Every Size. Do you want to talk a little bit about how we connected
Absolutely. Yes. So I found your podcast maybe a few months ago, just kind of wanting to learn about the space and seeing who's out there talking. I like to try and stay informed. And so I've been following your podcast, and then I heard about your book coming out. And as soon as it came out, I started listening to it, not only as a pediatrician or a pediatric obesity specialist, but also as a parent. Because I have 3 children that are elementary, middle school ages. Some of them have larger bodies and others don't. And so this is something that I'm not only dealing with professionally, but I'm also dealing with it personally. And so when I heard about your book, I started listening to it, and it really resonated with me. So I had to reach out to you. So I sent you an email and said, I just wanted to thank you for this book, because it really seemed to bring together the two parts of my brain, being a pediatrician and also being a mom, because I felt like I was hearing 2 different ends of the spectrum, and I was looking for where's the middle ground in here. And that's what I want to help my patients and parents with, is finding that middle ground. And I felt like you really were on the spot with it. So I was happy to just send you an email to say hello.
Yeah, no. And I so appreciated that, because when I wrote the book, I imagined I had myself a lot of conflict with the 2 polarization approaches. We're just focusing on physical health, as I showcase it in the book. We're only focusing on physical health, or we're only focusing on psychological well-being, and we really need to be focusing on both. And when I think about, and I'm curious if you have the same experience, but when I think about the clients that I take care of, when they come to me with concerns about their child who has a larger body, it's emotional. They are worried about the physical health, but they are just as worried about that child's well-being and how they view themselves and how they're operating in the world and their self-esteem and their worthiness. And oftentimes, in fact, I just did a book signing this week, and a person in the audience was like, I'm so emotional about this. You're bringing up so many emotions in me. And I'm like, it is emotional. And unless we start to acknowledge that this is all bundled up in a lot of emotions, we're not serving our families very well.
Yes.
Is that what you see too when people are coming to the pediatrician, and I'm assuming that they're sort of like, how healthy is my child? I'm worried about their health.
Yes.
But do you see this emotional component as well?
Very much so. And many times parents will bring their own history to the table, and their childhood and their experiences to the table. I can speak to that as a mom myself, having had, weight issues as a child, and now having children and seeing them kind of doing the same thing. I had to work on my mindset and kind of coach myself through to be like, okay, I know now the science behind it. I know that there's genetic factors. I know there's environmental factors and metabolic factors. There are things I can control and things I can't control. And I need to just make sure I do my work on myself first, and then I can work, with my children and serve them best. And so that's what I try to do also as a pediatrician, and trying to help families and parents, say, I can tell you when it's time to worry and when it's time to wait. Like maybe we don't need to be aggressive right now, or maybe now it is time to be aggressive. It's very much a continuum and a spectrum. And I think that's where I would like our pediatricians to also kind of jump in and think about it as a continuum. There's been a lot of debate about, the BMI and the growth charts, and whether or not that's the best use or best parameter in order to, classify children who have overweight or obesity. And is it perfect? No, absolutely. It's not perfect. It's designed to be just more of a screening tool, but unfortunately, it seems to have morphed into a diagnostic tool over the years.
Mm.
And so, as pediatricians, we're just kind of drilled in, okay, BMI XYZ, go do this, fix it, and it and we're given so little time in the office with families that we kind of have to just dive in and go with what we've been taught. And we don't always get that opportunity to take a second and do some critical thinking and asking extra questions.
Mm-hmm.
And so that's what I try to do with the extra training that I've gotten in this field, is that I really take a second and just say, let's slow down. Let's talk about it, and let's see where we can go forward from here, if we even need to go forward right now.
Right. No, that's such a great insight. And you do have extra training in this area. It's a specialty area. So I want
Yes.
to put that out there, and maybe you could describe some of the extra training that you've received, because I'm not sure parents really realize that this is a specialty area of medical practice.
Yes, absolutely. And even the general medical community may not be aware. I just kind of stumbled upon it myself too. It took 6 months of extra training and took a board certification exam, became board certified in obesity medicine. And, Jill, I graduated medical school in 2007. And so a lot has emerged in research and in science in this field, and recognizing obesity as a disease itself was something that I wasn't taught, and then once you're in training and then you're in practice, you just kind of don't learn the new stuff as easily. And so when I stumbled upon this new knowledge, I was like, where is this? Why isn't this out there and being told to everybody and taught to everyone? I'm hopeful that in the new graduates coming through are being taught this information, because that can help us really work through the internalized bias that we may have as physicians or as parents about it. By not understanding the true science that we know now. And thanks to the new developments, the new science, we now have different treatment options available, which we can get into a little bit later.
Yeah.
But many of my colleagues don't understand and don't know this, so it's definitely something that, I want to empower parents, that if your pediatrician seems to be harping in one direction and it's not resonating well with you, maybe seek out a pediatric obesity specialist in your area who knows more about this and can talk with you in more detail.
That's great. That's great. So as a pediatric obesity specialist, let's just walk through sort of how you look at a child in a larger body. And I do want you to touch on sort of the internalized bias that is often sort of present in any healthcare professional who's looking at a larger bodied child.
Yeah. So when they first look at the larger body child or see the growth chart, they might just be like, oh, this is a problem. We need to fix it. And that's where step one is maybe we don't need to fix it. That's the first bias, is if you think you have to go into action mode. So if I see a child with a larger body or a smaller body or whatever, I just try to look at them as a whole and say, how are you feeling today? How is it going? Do you have any concerns today? And just kind of let them start the conversation. And then I may ask for permission to the parent, and say, hey, may we look at the growth chart together today? Do you have concerns about your child's growth today? And then if given permission, we kind of discuss it and just look at trends over time. And if we notice there's been a change in the child's trajectory, and whether in height or weight or whatnot, instead of thinking, okay, what did you do wrong? What have you been feeding this kid? Again, take a step back. What's been happening in this last year? Has anything changed in the environment? Has anything changed in the social development? And just kind of asking questions rather than making assumptions is where I like to do.
Yeah. Yeah. I like that too. So say you have these conversations and you've been following a child for a while and you notice that they are accelerating on the weight curve. What do you do then? What does the conversation look like then?
Yeah. So then the conversation may be, after I've looked at the family history, if there are some concerning things, say in the family history, if I on exam may see some things that might suggest there could be something metabolic going on, we might have a discussion of maybe it's time we do some blood work and we kind of look inside and see metabolically how is the body functioning. And then we might proceed with blood work. And then after we've done the blood work, or maybe even genetic testing, we have the ability to do some genetic testing. That may help guide the next step in our conversation. If there are signs of metabolic dysfunction, okay, maybe we need to be a little bit more aggressive now because the body isn't functioning well. If metabolically everything is going well, emotionally, the child is doing well. They're not having any physical complaints. The family is doing their best at focusing on basics of getting rest and getting water and movement and all of the things. And we look at the development of the child. Like, is this the prepubertal teen? Is this a teen who's already been through puberty? That might also vary the conversation trajectory as well.
Mm-hmm. And can we just back up a second? I'm thinking of my audience, and you mentioned genetic testing.
Mm-hmm.
Sort of what does that mean for a child in a larger body? What are you really looking at in that situation?
Yeah, there are a few. There's more and more genes being discovered that can link to obesity, but there are a few genetic obesity syndromes that have specialized treatment. So really, when I'm doing the genetic testing, I'm looking to see if they may have that genetic syndrome that may need specialized medical treatment. Many times I've done the test and there's no genetic findings. Many times I've done the test and there are genes, but we don't know what the significance is. So it's not linked to those particular syndromes where we have specialized treatment. But yeah, we have these genes that we notice are associated more with families who have larger bodies. In some ways, that's helpful information for the families to just know that, like, yeah, I knew there was something in our family, and it's like, here is something. We don't know what to do about it, but here you go. There's just a little bit of information that's just there for you. But for me as a clinician, when I'm doing it, I'm specifically looking for those syndromes that may benefit from specialized treatment.
Yeah, yeah. And when I was doing the research for my book, I did spend quite a bit of time. And it's so funny, you write a lot and then you cull it down to like these 3 sentences. But I did spend a lot of time looking at sort of the genetic backbone around size. And to date, what I found was that 40 to 70% of a child's size is genetically determined in terms of roundness and propensity to carry extra body fat, which, again, I think for some families, this is a relief. It's like, it's not my fault. This is like built into my child. And on the other side of the coin, there's quite a bit of room that has an environmental influence. And when we're talking about the environment, we're talking about all these, I call them pillars of wellness. Lots of people call them healthy habits. And it's not just diet and exercise. I just want to shout that from the rooftops because I mean, it's just again, another bias that this is all down to diet and exercise. And it is not. There are things like sleep and how much screen time you use and the attitudes and your
cultural beliefs,
family influences, your social determinants, like your economic status, your educational status, or opportunities. So there's just so much that goes into it. When you, let's say you are working with a family and their child is showing body function disturbances. Sort of what's your filter? How are we proceeding sort of down this path?
Yeah. So if we found something, say high cholesterol that's developed, or we're heading toward prediabetes, that often would involve the help of our local dietitians to kind of work with the families one-on-one to see, because in those situations, there may very well be some dietary changes that need to take place to help. Just like with an adult, if you have high cholesterol, maybe eating less saturated fat in the diet is going to be helpful when we have the ability to do so. Again, going back to that social determinants of health, some things may not be in everyone's control. And that's where I love the dietitians to kind of work one-on-one with the families just to say, okay, here's this concern that we have. Let's see how we can try to modify. If we can modify anything, how can we do so? And give them actionable steps to do so.
Yeah. Every family is different. Every child is different. And it is a one-on-one game. It's not a one size fits all. We have these general guidelines and parameters that are good for everybody. And, but at the end of the day, it really is an individualistic sort of lens to help children. Yeah. So let's talk about, calling in the dietitian and how you work with a dietitian and what sort of your expectations or hopes are when you are pulling in the dietitian to the situation?
Mm-hmm. Yeah, my hope is for them to take that patient-centered approach and um, work with the families individually to help them formulate a plan that's practical and works with their lifestyle and isn't extreme. And, not every clinician is alike and not every dietitian is alike. And so I've had some families who have had great experiences and others who are like, here's a list of things to do. And it's completely opposite to what the family is currently doing, or they don't have access to all those resources. So that's not realistic for that family to follow that plan. So I really hope for our dietitians to work and make it patient centered and say, okay, well, here's what we are dealing with. Here's our goals. Where are we now? And how can we get there in a practical way, incrementally, so they can build confidence within the family and they can continue doing it at home.
Yeah. So much of my work with families in this situation is really empowering the parents to parent.
Yes.
And for some reason, and I think some of the listeners, I suspect some of my listeners out there, this will fall in their lap and they'll recognize this. But for some reason, when it comes to food, it's hard to parent food, especially when a child is larger, because we don't want to harm them. We don't want to hurt their feelings. We don't want to make them feel singled out. There's just so many, sometimes it seems barriers or personally perceived barriers to putting up those guidelines, governing the children's access to food. And I'm curious if you see the same. And I'm also curious as a parent, if you face this yourself.
Absolutely. 100%, Jill. I can't tell you how much this has come up for me in work and in my personal life, because I've learned about the different, parenting feeding styles, and you learn that over restriction can lead to disordered eating and kind of over desire for these foods, but then yet too permissive of an environment is also lead to, excess weight gain and other metabolic health concerns. So like, well, where do I fall here in the middle? I don't want to create a problem, but I also don't want to be too permissive. So kind of finding that middle ground of where you can have, I call them like respectful boundaries, where it's like, yeah, we have this, but there might be times that these things might be available, or kind of teaching them to listen to their bodies. But I also know scientifically from what I've learned that the fullness centers in the body might be not as audible, if you will, in the child. And so kind of teaching them to listen to their bodies, but knowing that they may not get that sense of fullness. So, 100% intuitive eating with whipped cream may not work. I had my son, he has also ADHD. You've discussed about in your book, executive functioning skills and the impulsivity. And I tried an experiment, like he loved marshmallows. And every time I bought marshmallows, it seemed like it was gone very quickly. So I said, I'm going to just try every week. I'm going to have them there. And it just never stopped. He just kept going more and more. And that's when I kind of had to say, okay, he doesn't have the skills right now. And I can help him create some limits for him and set some times, or, suggest, what we listen to our bodies and eat while not being distracted, or, just kind of getting some of that executive functioning, like planning ahead for these things, so that it's sending the message that these foods are okay. It's okay to have them, but it's also okay to not have them all the time impulsively in between meal times and snack times.
Yeah.
And so when I read that in your book, I was like, okay, I'm not the only one here who's like, there has to be some middle place here for governing.
And I think that is something that is not part of the conversation right now and probably deserves a little bit more attention. And that is that children, when they are younger, and I just want to preface this too with, I love intuitive eating. I consider myself an intuitive eater. I promote it, and we're all heading in that pathway. That is the goal.
Yes.
But I think that we also need to consider the fact that executive functioning skills are a big part of being an intuitive eater, like the ability to control yourself, the ability to forecast and make decisions into the future, the ability to not be distracted by your environment around you and to really tune into your body. And those skills develop over time. And 5-year-olds and 6-year-olds and 7-year-olds generally don't have those skills. And sometimes 13 and
Even
14.
middle schoolers.
Yeah, I was going to say, and sometimes 13 and 14 and 15-year-olds don't have that skill.
Yes.
And if you have a learning challenge or a behavioral challenge layered into that, those executive skills take longer to develop. And so in a lot of ways, sometimes I see this approach of, let the cookies out on the counter all day long, or let the child decide what they're going to eat and how much. For some kids, that's going to be setting them up for failure. Not all kids, but for some kids, it's just not going to be well handled.
Yes,
they just don't have the executive skills. They may not have the food approach. I talk about that too. The food responsiveness and satiety of responsiveness, and that's genetically baked in. And if a child is food responsive, they're always going to be turned on by food. If it's always out there, they're always going to be, they're always going to have one eye on it. It's just how they are.
Yeah.
And so
we want to not make that feel like it's a problem, right? Like that's
exactly.
Sometimes the parents are like, oh my gosh, my kid, he just loves food so much and he's always thinking about it. And, they're kind of fearful that this is a big problem. And it's like, maybe this isn't a problem. That's his nature. That's his trait. How can we support that and let him honor that he's hungry and wants more, but also give him choices that also meet the metabolic goals that we may have in mind. So I kind of try to instead of take away, how can I create more? Like a opt-in instead of an opt-out approach.
Yeah, I
and
love
then
that.
sometimes to take the emotions out of it, like you had said earlier. In terms of saying no to food at certain times, I said, okay, if this was a toy and you were in the grocery store aisle and this was a toy they were yelling to get, would you feel as hesitant to say no? And they're like, no, absolutely not. We're not buying that toy. And I'm like, well, it's the same thing. They're just reacting to the thing they want in that moment, whether it's food, whether it's a toy. You can parent them the same regardless of what it is. Yes, food is a right. You're always going to make sure that they're well nourished and they have opportunities to eat, but it's also okay if they're being impulsive in that moment and, throwing a tantrum, that it's okay to say not right now. Instead of no, how about not right now? Or if you really are hungry, here's this instead. It's your choice. And that way you can keep the conversation going and not make it this big thing like I'm saying no to my child. Oh no,
Right. Yeah. And I think that is, I think this little snippet of conversation will be very empowering and powerful for families that are out there listening, because it is sort of this, they get stuck in the, can I say no? What happens if I do say no? And some children need the no's. Children need those boundaries and that structure. And they really flourish when they have that, when they know what to expect and can operate within the boundaries and the environment that is, health promoting and nurturing and not causing harm. So let's dive into harm and how we potentially could cause harm to children with larger bodies. I would love to hear, from a pediatrician perspective, what you think about when you're thinking about the potential for psychological harm.
Oh yeah, there's always that. And I'm always thinking, that's what I'm worried about as a pediatrician. I really don't want to create an eating disordered eating or, potentially exacerbate something along those lines. So it's a very delicate conversation that needs to be had. But I think by not having any conversation, that's also doing harm. Like going back to obesity being a chronic disease and maybe genetically inherited, if we don't help, that could, create further metabolic problems down the road. So I always kind of take the frame of reference. If a child had asthma, I would help them in their environment the best way I can, but sometimes they still need medications in order for them to have their lungs functioning properly. Same thing with obesity. We can do what we can in the environment, but at some point we may need to get more medical treatment when needed. My biggest concern, especially if I have parents who may not have grown up with larger bodies or may not have had a family history of that, and then they have a child who does have a larger body, that they try to focus on their physical appearance and trying to make them look a certain way and ignoring all of the other aspects of their health and ignoring their emotional health and their psychological health. And, when they come into me and they're like, she has a big tummy and I want her to wear whatever she wants to wear, so she needs to lose weight. I kind of cringe inside and be like, that's really not the conversation we need to be having. Or I've had somebody and she's lazy, she doesn't like to move. And it's like, those words can hurt, that's going to be harming the child. And this could happen in any family, not just with parents who are smaller bodied, even with parents who are larger bodied, who have may dealt with things and they're fearful and worried about the bullying their child may experience or what, negative impacts their larger body may have on them in the future. They can kind of go into panic mode and just really kind of blame the kid and try to over control them. So then they might be over restricting, like we talked about earlier, like we're never eating any of these foods. You can't have that. No, you can't have this. And that's being too much like a dictator. That's not healthy either, right? Health is,
Yeah.
I like to redefine health. What is health? It's not just your physical health. It's all of your health, your emotional, your physical, your metabolic, your psychological, all put together. And so we need to address all the parts. And sometimes the child might be dealing mentally and emotionally. Their health is not well, and that's a bigger priority. And so we may not talk about weight or lifestyle modification, and we're going to focus more on getting their mental health in control first.
Yeah.
And that's what I hope my co-pediatricians out there might consider as well, that when you see the growth chart and you see someone with a larger body, instead of, again, driving into, we have to fix this mode, take a step back and look at the whole child and see, like, are we at a place right now where this makes sense or not? Because I don't want to do harm. Because if we dive into, we have to fix this medical problem, we could be doing harm on the emotional aspect of it, and that's not healthy either.
Yeah. Yeah. So, I wanted to shift to some of the treatment options. You hinted to that earlier on, and I want to preface this with, lifestyle habits for some children will be enough, right? Just getting those lifestyle habits in the right place. And I experience this myself with the families that I work with. We work on the habits and the habits of sleep and food choice and feeding and building eating habits, all the things in the book, the 8 pillars of wellness. We work on that pretty intensively. And I'm pretty confident that my patients are well rested, well nourished, feel good about moving their bodies. Even if their bodies are larger, they feel good in the movement that they're able to do. I'm confident that they're eating better, they're eating more mindfully. So all of these little benefits. But I also acknowledge that will not be enough for some children. And it will not reverse their metabolic health. So when we talk treatment options, in my mind, I'm thinking of treatment for the child who has worked on health habits, who has or at least been asked to work on health habits, who needs more support than that to address their metabolic health. So that's what I wanted to preface this with, so that parents were thinking about this sort of like in our same way. And do you agree? Do you agree with that approach, Dr. Zeena? Okay.
Oh yeah, absolutely.
Okay. So let's talk about then, for those children who need more than just we're rehabilitating our lifestyle habits, what are we talking about in terms of treatment options?
Yeah, there are a few treatment options. There's always more and more emerging as time goes on. But the most common one that most families have probably heard about is the injectable GLP-1 agonists. There's some that are daily ones, like Saxenda is one brand name, or liraglutide, or then semaglutide or Wegovy, which is a weekly injection. And those have an indication for 12 years and up in patients who have obesity and or metabolic complications or comorbidities from obesity.
And I just saw, in fact, I tried to get an opinion piece submitted on this topic, but there's been a recent study that has shown that Saxenda or liraglutide is safe for children as young as 6 years of age. I'm just curious about what you think about that.
Yeah, it's very nuanced, right? Because on the one hand, we know that obesity can drive these secondary comorbidities like diabetes and high blood pressure and high cholesterol. And, as pediatricians, we like prevention, right? We don't like to wait for problems to develop before we start treatment. And so the Academy of Pediatrics and their guidelines for treating obesity kind of suggest treatment through prevention, right? And one could argue in some cases, not for everyone, but in some cases, treating with these medications might be preventing further future problems. Why does the child have to have fatty liver for us to then have to go and reverse it? If I know that the family lifestyles are in check and genetically, metabolically, this is how the body is dysfunctioning, because it is a dysfunction in some ways of the body, maybe I don't want the problem to develop in order to treat it. But it's very nuanced. And I think in some cases I've seen where it might be very beneficial for a child of that age because, in 2 years, they're going to have fatty liver. And so instead of waiting till 12 and it's a bigger problem, maybe treating them at 8 years old, for example, may help that. And then you have to think about physically, it might help their joints. Maybe they won't have joint aches and pains, which then might facilitate more movement and then, being able to keep some of those lifestyle modifications in check or on par, if you will. Their social and emotional well-being. We know that bullying is something that a lot of children deal with. And so why get to an extreme and then just suffering from anxiety and depression and whatnot, where we might have been able to help them sooner. And that gets into another conversation of we need to accept all bodies of all sizes. And I agree with that 100%. We need to just kind of normalize and accept that we're all different sizes and shapes. But we also know that this patient population is still stigmatized quite a bit and suffers a lot mentally and emotionally from their peers in school. And so, it's very fine balance and very nuanced. It might be appropriate for some, but maybe not be appropriate for everyone.
Through my lens of being a pediatric dietitian, when I think about a 6-year-old, I think, wow, I can just get so many good habits on board with that family. I feel like they're so responsive. Their little bodies are so responsive to good habits. And at the same time, I recognize that some families just will not be able to implement those lifestyle habits. And that's the truth of the matter. I mean,
yes,
I can Pollyanna it and think I could save everybody. Let me get my hands on these families and let me help them. And at the same time, I also understand that, it's just, it may be unattainable for some families. They just, given, their circumstances, just may not be able to implement those lifestyle habits and behaviors on a consistent basis. I think as we travel down the road of treatment for this condition, these are the sort of tough questions, tough scenarios where we really do have to be individually focused, I think. And because it is so nuanced, right? It's not that these studies are not saying treat every child who is 6. These studies, and I caution, even healthcare professionals out there who, and I'm not saying that I'm not pro nor against. I am like, every child is different and every family is different. And it has to be the decision of the family and the healthcare team. Because again, everybody is so different. And, but yeah, these are tough scenarios and tough situations to navigate.
It is. That's why I always say it has to be patient-centered. All of our guidelines and recommendations and treatment options, it has to be patient-centered, patient-driven. Some families don't want medications at all. Some families come in wanting medications right away, and I have to counsel both and be like, maybe medication isn't appropriate, maybe we need to try XYZ. In a perfect world, I would love to blend together the lifestyle modification along with the medication pieces together to bring the most success.
Mm-hmm.
And in practicality, the medication options, even though there's approval and availability, it's not always financially available to everyone. Mm-hmm. Many times I have patients who would benefit tremendously from the medications, but unfortunately their insurance will not cover it, or it's covered, but the full cost is on the patient. And we're talking $1,400 a month. And most families can't afford that at all.
Mm-hmm.
And that's not fair. And that's doing a disservice. And it's also a privilege for me to think that lifestyle modifications is attainable for every family.
Right.
So that goes back to the social determinants of health. So it's so complex and so complicated, but it can be handled or navigated with the family alongside. It's definitely a partnership. We have to work hand in hand together. And so I don't want it to be polarized. If you have to be team medicine or team lifestyle, it's going to be both in some way, shape, or form. And it's a spectrum and a continuum. At some points in the child's life, it might be lifestyle. At some point in the child's life, we might need medication plus lifestyle, and so or surgery, let's not discount that there still is the need for bariatric surgery in some patients. So it's definitely a spectrum. It's definitely a continuum. And it's something to just keep having conversations and not just say, oh, here you are, and this is what you have to do. X done. That's it. You got to leave, follow this one path.
Yeah. So as we sort of wrap up this conversation, what is it that you would want parents out there who are listening, or even professionals who are listening, that may be taking care of or parenting a larger child, a child who has a larger body? What do you want them? What is the most important things for them to think about, to consider?
Wow, there's so many things for them to consider. But I would say, I would like to empower them to talk to their doctor, and also empower them that if what they're hearing from their doctor is not resonating with them, to seek out additional help and advice. Because and not to think that all pediatricians are bad if they bring up something. I feel like we're getting, in some communities, we're villainized for trying to treat obesity, and others, we're villainized for even continuing to use the growth charts and measuring, but you can also advocate for your child and say, hey, I'd love to have this conversation with you in private, not in front of my child. Feel free to speak up and say that. Also feel free to say, if your pediatrician isn't providing you all the treatment options available to you, to speak up and ask questions. Can I see someone else? So just keep the conversation open and flowing, and don't panic. There's so much fear involved in it, fear of doing harm, fear of the medical complications. It's okay. We're going to be okay. We're having the conversation. We will find the right path. We will find the right answer together, hand in hand. So I hope that each family finds their medical team that can work with them, that they're comfortable with, to work with the patient and the family as a whole, all together. Just let's all come together.
Yeah, that's great. Well, Dr. Zeena, it has been such a pleasure to have this conversation with you today. Where can people connect with you and find you?
Thank you so much, Jill, again, for having me on the podcast today. If parents like to follow me, I'm on social media. I'm on Instagram and TikTok at Dr._Zeena_MD. And I have a website with a little bit of information about my clinic that I have here in Michigan.
Awesome. Well, thank you again so much. And thank you for the work that you do on behalf of the children in our country. It's wonderful.
Thank you. Same to you, Jill.
That's it for today, folks. I hope you enjoyed this conversation with Dr. Zeena. You can find her at drzeena.com and follow her on Instagram, TikTok, and Facebook. Before I go, though, I want to just say that if you haven't purchased Kids Thrive at Every Size, you can get it at Amazon, at Barnes & Noble, at independent bookstores. I encourage you to get a copy of it. You do not have to have a small child or a larger-bodied child to have this book be completely and thoroughly very useful for you. If you do have the book, if you've read it, if it's sitting on your bookshelf, would you please head over to Amazon and leave me a review? It helps tremendously with the algorithm, and it helps other families find this book, which can be so helpful to so many, I believe. If you're struggling with your child and you want personalized professional help, I do offer that for a handful of families. You can head to my website, jillcastle.com, and you will be able to see under my consulting tab the services that I offer. I hope you're having a fabulous week, and make sure you give that child in your life a loving squeeze today. Bye for now.
Thanks for listening to the Nourished Child Podcast, where the #1 goal is to help you grow a nourished child inside and out.